Dear student, I am Dr. Prakash Mungli, a professor in biochemistry. So in this video, I will be explaining you enzymes in clinical diagnosis. Before we get into enzymes in clinical diagnosis details, let us understand what are plasma enzymes. Meaning the enzymes that are present in the plasma, how they come there and what is the function of plasma enzymes in the plasma, that's in the bloodstream. So enzymes in the plasma can be classified depending on their original location into intracellular plasma enzymes and extracellular plasma enzymes. As the name says, plasma enzymes which are coming from extracellular space into the plasma, those are extracellular plasma enzymes. And intracellular plasma enzymes are the plasma enzymes that are coming from the cell. Because you need to remember here, we are looking at enzymes that are present in the plasma, that's in the bloodstream. And by the classification here, that is extracellular plasma enzyme, meaning outside the cell, that is in the extracellular matrix, whatever the enzymes that were there in the extracellular matrix, now they got into the bloodstream. What is the function of those enzymes in the plasma, which are coming from the extracellular matrix? And also, we are going to find enzymes that are coming from inside the cell into the plasma. In order to explain that to you, so I am going to write a few cells here and also the extracellular matrix and a blood vessel. That's where is your plasma, right? So enzymes that are present in the extracellular matrix, so I am writing that as E in the in green color, and enzymes that are present inside the cell, I'll write E in blue color here. Okay, so whenever there is a cell turnover, means when cell dies, the content in the cell usually gets into the plasma, right? So here enzyme from the cell, which is an intracellular enzyme, find its way into the plasma. Similarly, extracellular enzyme will also find its way into the plasma. So this is how extracellular plasma enzymes and intracellular plasma enzymes will get into the plasma. And when we determine their levels, we will see a certain range of these enzymes in the plasma, and this range under normal condition do not vary in a person. It will be a range. A normal range will be there for every enzyme. Now, what is the function of these enzymes in the plasma? Majority of these enzymes in the plasma coming from the extracellular matrix or coming from the intracellular side, like maybe cytoplasm or mitochondria or any other subcellular organelles, they do not have any function in the plasma, or they may have very insignificant function in the plasma. So let's look at some of the examples for extracellular plasma enzymes and intracellular plasma enzymes. So example for extracellular plasma enzymes, that means which function outside the cell or in the bloodstream. So we have clotting factors which are there in the bloodstream itself. They are outside the cell, that means they are outside white blood cell, red blood cell or platelets, they are there in the blood itself. Or lipoprotein lipase. This lipoprotein lipase, it is attached to the endothelium of capillaries. So these are extracellular plasma enzymes. Some of the enzymes that were present in the extracellular matrix, like lysyl oxidase, which is there in the extracellular matrix. You can also find that in the plasma. Coming to intracellular plasma enzymes, like enzymes which have got function within the cell, but now you are going to find that in the plasma. Example, creatine kinase. This creatine kinase enzyme, it is there inside the cell. So whenever cell undergoes normal cell turnover, so the cellular content enters into the plasma and you are going to find that enzyme levels in the plasma, in the blood, although creatine kinase do not have any function in the plasma. Similarly, lactate dehydrogenase. Lactate dehydrogenase is there in the red blood cell, conducting anaerobic glycolysis. So when red blood cell dies, if there is an intravascular hemolysis, so lactate dehydrogenase simply gets out of the red blood cell and you are going to find it in the plasma. So this is how you are going to find extracellular plasma enzymes and intracellular plasma enzymes. That's what is the meaning of plasma enzymes. Now, the levels of plasma enzymes correlate with the extent of tissue damage. If the tissue damage is too much or severe, there will be increase in the plasma enzymes depending on which tissue has died or which cells are dying. So depending on that, we can determine what kind of tissue is dying, what kind of cell death is going on. If we know, okay, that particular cell has a specific enzyme which is located there, and if you find that particular enzyme in the plasma, we can determine by determining the plasma enzyme exactly from which tissue it is coming from and which tissue has been damaged. Otherwise, the levels of plasma enzymes are fairly constant in healthy individuals unless there is any disorder going on. So, increase in the plasma levels of intracellular enzymes indicates damage to plasma membrane and leakage of these plasma enzymes into the plasma. So, that means plasma enzymes, they correlate with the extent of tissue damage. Now, before we get into enzymes which are used in clinical diagnosis, let's understand what is the meaning of isoenzymes. Physically, these enzymes are distinct, but they catalyze the same reaction and they are present in different tissues. Just to understand isoenzymes concept, let's take an example of lactate dehydrogenase, which is abbreviated as LDH. As you see here in the table, there are 5 types of lactate dehydrogenase, and lactate dehydrogenase is a tetramer. That means it has got 4 subunits. There is a H subunit and there is a M subunit, H for heart, M for muscle. Now, since it's a tetramer, if all the 4 subunits are of H type, that is H4, then that type of lactate dehydrogenase, we simply call it as LDH1, and that's what is shown here in the table, that is in the row number 1, it is H4 LDH1, and LDH1 is specifically present in the heart. Like at high concentration, you are going to find that in the heart muscle. Coming to LDH2, it has 3 H subunit and 1 M subunit, and LDH2 we are going to find that in red blood cell and kidney. LDH3, it has 2 H subunit and 2 M subunit, and it is found in spleen, lungs, lymph nodes, leukocytes, platelets. LDH4, it has 1 H subunit and 3 M subunit, and we are going to find that in the liver and skeletal muscle. Similarly, LDH5, which has 4 M subunit, and we are going to find that in the skeletal muscle. So, like this, different isoenzyme forms of lactate dehydrogenase can be seen, and these are catalyzing the same reaction. What is that reaction lactate dehydrogenase catalyze? Lactate dehydrogenase converts a pyruvate into lactate. Conversion of pyruvate into lactate, it's a reversible reaction where pyruvate is reduced into lactate, and that is done by enzyme lactate dehydrogenase. Okay, so in this reaction, NADH plus is oxidized into NAD plus, while pyruvate is reduced into lactate. Right? So this type of reaction is catalyzed in variety of tissues, and there are different enzymes in these tissues, and these enzymes catalyzing the same reaction present in different tissues are referred as isoenzymes of lactate dehydrogenase. So we have 5 isoenzymes of lactate dehydrogenase. Similarly, we have another enzyme which will show a isoenzyme pattern, that is creatine kinase, CK. This creatine kinase, it has 2 subunit. One is a B subunit, B for brain, and other is M subunit, M for muscle. And there are 2 subunits in creatine kinase. So if it is both the subunits are of BB type, it is creatine kinase number 1, that is CK1, which is just 1% of total CK in the plasma. And the CK1, it will come from brain. Now CK2, it is B subunit and M subunit combination is CK2, and it is present in the heart, and it is roughly around 5% of total creatine kinase in the plasma. Now CK3 is, if both the subunits are of M type, it is CK3, and this is the predominant type of creatine kinase that we are going to find in the plasma. And out of total creatine kinase, all total together CK1, CK2, CK3, out of total creatine kinase, 80% of the creatine kinase that is found in the plasma is contributed by CK3, that is skeletal muscle creatine kinase. Now, whenever there is changes in the creatine kinase isoenzyme levels in the plasma, that indicates certain clinical significance to it. If there is a rise in the creatine kinase CK2, if there is a rise in CK2 or CKMB, it indicates there may be myocardial damage, and the myocardial damage includes myocardial infarction. And if you see a rise in CK3, that is isoenzyme, generally it is seen whenever there is a damage to the skeletal muscle. Example, muscular dystrophy or injury to skeletal muscle may lead to increase in CKMM type. And also there are some atypical creatine kinases that can be found in the plasma. One is a CK macro. CK macro, it is an aggregation of creatine kinase BB with immunoglobulins. Immunoglobulins along with CKBB, we refer it as CK macro. Then we have CK-MI. So CK-MI, it is a mitochondrial creatine kinase which is observed in the external surface of inner mitochondrial membrane of muscle, liver and brain. So these are some of the isoenzymes of creatine kinase. Now let's move on to see isoenzymes of alkaline phosphatase. Now the alkaline phosphatase isoenzymes can be divided into alpha-1 alkaline phosphatase, alpha-2 heat labile alkaline phosphatase, alpha-2 heat stable alkaline phosphatase, pre-beta alkaline phosphatase, gamma alkaline phosphatase and leukocyte alkaline phosphatase. And they are present in different tissues as shown in the table here. And one of the point I would like to mention here is alpha-2 heat stable alkaline phosphatase. As the name says, it is the most heat stable alkaline phosphatase and it is inhibited by phenylalanine and it is produced by placenta. Make sure you remember that. So alkaline phosphatase can also be produced by the biliary canaliculi, that is alkaline phosphatase, alpha-1 alkaline phosphatase from the biliary canaliculi. Alpha-2 heat labile alkaline phosphatase is coming from hepatocytes. Pre-beta alkaline phosphatase coming from osteoblasts. Gamma alkaline phosphatase coming from intestinal cells and leukocyte alkaline phosphatase coming from leukocytes. That means depending on which type of alkaline phosphatase levels are elevated in the plasma, we will determine what type of tissue damage is going on there in our body. So that's where our use of these isoenzymes comes in the clinical diagnosis. Because if you are suspecting an injury in a particular tissue based on the history and clinical examination, when you want to determine or confirm the diagnosis, so you can always ask for the enzyme that may be specifically present in that particular tissue, and if a result comes out that that particular enzyme that you are looking for as levels of that enzyme is raised in the plasma, and your diagnosis is almost correct there, because the enzyme levels that are coming specifically located in that tissue, if they are raised in the plasma compared to the normal range, that means there is a damage to the tissue where you have suspected. Okay, and that's where isoenzyme comes into clinical diagnosis. That's how we can use determining plasma enzyme levels in the diagnosis and monitoring of disease. So let's briefly look at features of isoenzymes. So they are different physical forms but catalyze the same chemical reaction in different tissues. They differ in heat stability that we have seen, heat stable alkaline phosphatase, heat labile alkaline phosphatase. They can differ in electrophoretic mobility also, like CK1, creatine kinase 1 enzyme moves faster than CK3, and their susceptibility to inhibitor can be different, like tartrate labile acid phosphatase and tartrate stable acid phosphatase enzymes. The subunit combination made is also different in isoenzymes, like lactate dehydrogenase 1 and lactate dehydrogenase 5, and they differ in tissue locations also, like LDH1 is located in the heart whereas LDH5 is located in the muscle, and they differ in Km value also, like glucokinase, which is an isoenzyme of hexokinase. Glucokinase has a higher Km, but hexokinase has a lower Km. Like this, isoenzymes, they differ in various characteristics, although they catalyze the same reaction, but they are physically distinct forms and they have distinct kinetic characteristics. Now let's move on to see biochemical markers of myocardial infarction. This is an example to appreciate how enzymes that are present in the plasma or how proteins that are elevated in the plasma, how they can be used in the clinical diagnosis. This is just an example. So I am taking myocardial infarction as an example to teach you how exactly we can use enzyme levels and protein levels coming from specific tissues being elevated in the plasma. Basically, they are all leaked from that specific tissue like heart into the plasma and their levels are rising, and how we can use that information in the diagnosis and monitoring of a disorder. So, myocardial infarction, injury to the myocardium because of lack of blood circulation to specific area in the myocardial tissue. So, let me write it down here. So, it is a heart, left anterior descending artery, and generally the left anterior descending artery is, that's where is the most common blockage happens, and the area supplied by the distal part of this artery, wherever there is a blockage, so it will get less oxygenated blood, so there is a decrease in the oxygen level. So when there is a decrease in oxygen level there, so it will go into anaerobic glycolysis just to survive. So that means this area here, it will start to die and cell membrane will break open, mitochondrial membrane will break open, and the things present in the cardiocytes will be released, and it will be released into the bloodstream and they start to leak out into the blood. So basically you are going to find elevated levels of these cardiac proteins and cardiac enzymes in the blood now. So I am going to show it separately, that there will be elevation of cardiac proteins and cardiac enzymes in the blood. So blood levels of cardiac proteins and enzymes will be elevated. Now if we can measure certain types of cardiac proteins and cardiac enzymes in the blood, so we can determine the diagnosis, we can also monitor the treatment. Now, what are the proteins and enzymes that we are using in the diagnosis of myocardial infarction? So, our first biochemical marker of myocardial infarction or heart injury is heart type fatty acid binding protein. And this heart type fatty acid binding protein, it takes around 60 minutes after cell injury, like chest pain. From the point of chest pain, it takes 60 minutes to appear in the plasma. That's how quick it is. And then it is going to be peaked by 6 to 12 hours, and after that it is slowly washed out of the system by 1 to 1.5 days. You got to remember the timeline here. Creatine kinase MB. Creatine kinase MB, it appears in the plasma 3 to 6 hours after chest pain. It peaks by 12 to 24 hours and it will be washed out of this system, means circulation, by 2 to 3 days. That's the timeline for creatine kinase MB. Cardiac specific troponin T's, that is CTNT, and cardiac specific troponin I, that is CTNI. These are cardiac proteins and they are highly sensitive and highly specific markers of cardiac damage. So they appear in the plasma 3 to 5 hours following chest pain, and they reach peak by 12 to 24 hours, and they take around 7 to 10 days to reach baseline. Now you need to differentiate the difference between creatine kinase MB and cardiac troponin T and cardiac troponin I. Look at the timeline now. Creatine kinase MB, it takes around 2 to 3 days to come back to the baseline, whereas cardiac specific troponin T and cardiac specific troponin I, it takes 7 to 10 days to reach baseline. That's where is the difference. Difference is it takes 7 to 10 days for cardiac troponin T's and cardiac troponin I's to come back to the baseline. That means they are going to stay there for a long time compared to creatine kinase MB. So it means creatine kinase MB, since it appears, it comes back to the baseline within 2 to 3 days. So the late diagnosis of myocardial infarction, like if a person comes to hospital 3 days after chest pain, simply we cannot use creatine kinase MB for diagnosis. At that time, we should use cardiac troponin T's and cardiac troponin I's for the diagnosis in the late diagnosis. What about early diagnosis? If the person appears to hospital within 24 hours, so we can either use creatine kinase MB and cardiac troponin T's or cardiac troponin I's. But again, we prefer to use cardiac troponin T and cardiac troponin I because these are highly sensitive and highly specific markers of cardiac damage compared to CKMB. Although we still determine the levels of CKMB even if we are doing cardiac troponins, because we are going to use CKMB later, like after 3-4 days. Still we need CKMB information because if we need to diagnose what is called as reperfusion injury. I am going to teach you what is reperfusion injury. So in order to diagnose reperfusion injury, so we need information on creatine kinase MB. That's why although cardiac troponin T's and cardiac troponin I's are highly sensitive and highly specific markers of cardiac damage, we also determine creatine kinase MB always. So the use of creatine kinase MB is not in the initial diagnosis of myocardial infarction, which of course we can do using cardiac troponins, but it is used in the reperfusion injury diagnosis. Now, what are the other markers of myocardial infarction or heart damage which are of historical importance? I would say historical importance because nowadays we generally don't use these markers in the diagnosis of myocardial infarction. But for a theoretical point of view, it is good to know what were the other markers that were used before. It is myoglobin. Myoglobin appears early, like 2 to 3 hours after chest pain, peaks by 6 to 12 hours and reach baseline by 1 to 2 days. It's a low molecular weight protein, so it will be filtered in the urine. So there will be myoglobinuria also. But only thing is, it is a least sensitive marker of myocardial damage because even a trivial injury to skeletal muscle might increase in myoglobin. Aspartate transaminase, previously it was called as SGOT. So it appears in the plasma 6 to 8 hours after cellular injury, peaks by 2 to 3 days and returns to baseline by 7 to 10 days. It looks like a cardiac troponin timeline, but it's of less significance because aspartate transaminase not only present in the cardiac tissue, it is present in most of our cells, and that's why it is not a specific marker there. Lactate dehydrogenase similarly appears to 8 hours of chest pain, peaks by 1 to 1.5 days, return to baseline by 4 to 6 days. Again, it is not a specific marker for myocardial damage. It can come from red blood cells or any tissue conducting anaerobic glycolysis. Coming to flipped pattern of lactate dehydrogenase. Normally, lactate dehydrogenase 2 is present at high concentration than lactate dehydrogenase 1. Note that lactate dehydrogenase 2 is present in the red blood cell, lactate dehydrogenase 1 is present in the heart. So, there is more LDH2 than LDH1. If there is an increase in LDH1 than LDH2, basically there is a flipped pattern there. Let me write it down. So, if this is LDH1 and this is LDH2 in the normal pattern, so LDH1 and LDH2. So LDH2 is at higher concentration normally than LDH1. So in the myocardial infarction, that is MI, what happens is, so LDH1 will be much higher and then LDH2. Okay, so this is a flipped pattern and that is what is seen in myocardial infarction. Now this particular graph is indicating some of the cardiac markers that are elevated in the myocardial infarction. So you can see here A, that is myoglobin, which is of historical importance, not really sensitive marker, and the B1 is troponin. In the large infarction, you can see there is higher increase in troponins because the area under the curve is much bigger. That means more amount of troponin is released into the bloodstream. And if it is an infarction is small, like a small area of heart is kind of undergoing infarction, so usually that is referred as 𝐿-STEMI, that is non-ST segment elevated myocardial infarction, where small area is dying. So area under the curve is smaller. So that means my point here is, if you compare between B1 and B2, so B1 has a larger area under this curve, so indicating that bigger area of the heart is dying. And if the area under the curve is smaller, so small area of the heart is dying. So we can also use this kind of information in knowing the severity of myocardial infarction, because there is a difference between STEMI and 𝑁-STEMI. STEMI is ST segment elevation myocardial infarction in the ECG electrocardiogram. 𝑁-STEMI is non-ST segment elevation myocardial infarction, which is a small infarction. So amount of enzyme being elevated will also indicate the severity of the disease. That's one of the useful information that we can get from determining enzyme levels or protein levels in the blood in the diagnosis process. Now the 𝐶KMB, look at 𝐶KMB. Area under the curve is 𝐶KMB relatively less, it is rising early, and also it is coming back to the baseline relatively early. By 2 to 3 days, it is already there in the baseline. Now imagine that if a person is coming to the hospital, 24 hours chest pain, and we have measured cardiac troponins and also 𝐶KMB, and person has been given a proper treatment, and after 2 to 3 days, if there is any re-injury to myocardium, it's maybe because of the part of the treatment also. Whenever recanalization, when the blockage of the coronary is there, when the treatment is done, when the block is removed and the blood is flowing back into the area that was previously anaerobic. So because of the sudden gush of blood into that area, so there can be mitochondrial electron transport chain is restarted, already partially damaged mitochondrial membrane, restarting the electron transport chain might really increase reactive oxygen species molecule or the free radicals, and these free radicals can lead to damage to the myocardium, and that damage to the myocardium, because of the reperfusion, because of the fresh blood coming in there, more oxygen coming in there, causing a injury, again that is referred as reperfusion injury, and that leads to damage to the fresh myocardial tissues and release of content like 𝐶KMB, troponins and all that. Note that by 2 to 3 days 𝐶KMB already came down to the baseline, but the reperfusion injury generally happens 2 to 3 days after, and now because of that 𝐶KMB start to rise again. Alright, so why can't we use troponins instead of 𝐶KMB? Because troponins, as you see here, it is still at high levels. By 2 to 3 days, it is still at high levels. So a little bit rise in the troponins may not give that significant diagnosis, because we may not notice it also. Whereas here 𝐶KMB already it has reached baseline, and if it start to rise again, it's a clear indication that there is again a damage to the myocardium. So that's where 𝐶KMB comes in. That is why I was saying, when we analyze the marker for myocardial infarction, although troponin clearly wins as a highly sensitive and high specific marker for myocardial damage, we still do 𝐶KMB because we want to keep monitoring or keep looking for reperfusion injury, just in case. Not everyone goes into reperfusion injury. Just in case if there is a reperfusion injury, so we can find it out only when we serially monitor 𝐶KMB along with troponin. Okay. So now let's look at this slide. So the troponin without reperfusion, troponin with reperfusion, 𝐶KMB without reperfusion, and 𝐶KMB with reperfusion. So whenever we attempt a treatment, reperfusion is done, so there will be washing of the area which was previously dying, and because of this washing effect, you will see a sharp curves in this enzymes. So that's why you compare here. So the blue line with the red line for troponins without and with reperfusion injury. So always with reperfusion injury, there will be sharp rise in the curves and sharp fall in the curves. That's because of the washing effect. When the new blood gushes in, the things are washed out, and that's why you see the sharp curves. So this is the reperfusion. I'm not saying about the reperfusion injury. Now the reperfusion injury, which I have explained, Reperfusion injury is when oxygen allows a recovery of oxidative phosphorylation process. So, reperfusion with oxygen increases generation of oxygen and nitrogen free radicals, further damaging the myocardium or the cardiocytes. The extent of reperfusion injury can be determined by measuring blood levels of 𝐒𝐾MB. The reason for using 𝐒𝐾MB over cardiac troponin is 𝐒𝐾MB normally returns to baseline by 2 to 3 days compared to cardiac troponins, which usually takes 7 to 10 days to reach baseline. So remember, we use 𝐒𝐾MB for reperfusion injury after myocardial infarction. Now let's look at briefly enzyme profile for liver diseases. So we use aminotransferases. There are 2 aminotransferases that are sensitive indicators of liver cell injury. One is aspartate transaminase, other is alanine transaminase. Out of these 2, alanine transaminase is primarily found in the liver, and therefore it is relatively more specific for liver disease than aspartate transaminase. Only thing is, in the hepatocellular diseases, alanine transaminase is slightly higher than or equal to aspartate transaminase. So if you look at the ratio, so ALT over AST ratio will be more than 1. That meaning in hepatocellular damage or hepatocellular diseases, alanine transaminase is much higher than the aspartate transaminase, especially coming from the cytoplasm. Now, in alcoholic cirrhosis, what happens? In alcoholic cirrhosis, especially cirrhosis caused because of the alcohol damages not only the plasma membrane, it also damages mitochondrial membrane. And damage to the mitochondrial membrane will release a mitochondrial aspartate transaminase into the cytoplasm, and from there it appears in the plasma. So in that condition, if you measure ALT over AST, so AST will be much higher than the ALT, so the ratio will be less than 1. Or if I want to rewrite in other way around, so if I am writing AST over ALT ratio, in hepatocellular disease condition, because ALT is more than AST, ratio will be less than 1. In alcoholic cirrhosis, so the AST over ALT ratio will be more than 1, because AST will be much higher than the ALT. And this is referred as de-Ritis criteria. De-Ritis criteria for diagnosis of hepatocellular pattern of liver injury, then alcoholic cirrhosis pattern of liver injury. Now, what are the other enzyme profile that we use in the liver diagnosis of liver diseases? So, we have 5' nucleotidase, which is more specific than alkaline phosphatase and gamma glutamyl transpeptidase. Alkaline phosphatase is used in the diagnosis of biliary canalicular diseases or extrahepatic canalicular diseases. Gamma glutamyl transpeptidase enzyme, GGT, it is mainly used to identify alcohol abuse or alcohol use leading to liver damage. Enzyme markers in prostatic cancer, we can measure tartrate labile acid phosphatase or prostate specific antigen, also known as kallikrein related peptidase 3, that is KLK3. It is a serine protease secreted by epithelial cells of prostate. This prostate specific, and it is not a prostate cancer specific. That means damage to the prostate may lead to elevation of prostate specific antigen. Not necessarily it means that there is cancer in the prostatic tissue. So PSA levels estimation should be accompanied by prostate biopsy, and the commonly used cutoff point for prostate cancer for the PSA levels will be more than 4 nanograms per ml. So always PSA has to be accompanied by prostate biopsy, just to confirm if it is just a benign hypertrophy or the cancerous change in the prostate gland. Now coming to the enzyme markers of pancreatitis. And the pancreatitis can be diagnosed by measuring amylase, plasma amylase, plasma lipase. Out of amylase and lipase, serum amylase is not specific for pancreatic disease as its level is increased in pancreatitis and is also increased in the urine. So serum lipase is more specific because level measurement can be used for differentiating pancreatic and non-pancreatic cause for hyperamylase. Now, markers of bone formation. So, we have serum bone specific alkaline phosphatase, serum osteocalcin and serum propeptide of type 1 procollagen can be used as a marker of bone formation. So, we can use bone specific alkaline phosphatase, osteocalcin and pre-peptide of type 1 collagen, because type 1 collagen is found in the bone, collagen that is present in the bone. Coming to markers of bone resorption. So, we can measure urine and serum a cross-linked N-telopeptide. We can measure urine and serum cross-linked C-telopeptide, and also we can measure urine total free deoxypyridinoline. These are the markers of bone resorption. Now, to recap all the enzymes used in clinical diagnosis, a table here is enumerating some of the important enzymes that are used in clinical diagnosis. So, we have aspartate transaminase, alanine transaminase, alkaline phosphatase, acid phosphatase, and then we have lactate dehydrogenase, gamma glutamyl transpeptidase, creatine kinase, amylase, which is raised 100,000 folds in acute pancreatitis. We have lipase, prostate specific antigen. These are the markers that are used in clinical diagnosis. Examples of markers of organelle and membranes. So, plasma membrane enzymes that are located on the plasma membrane. So, we have 3 enzymes that are used as a marker. One is 5' nucleotidase, adenylyl cyclase and sodium potassium ATPase. All these enzymes are located over plasma membrane, and we can use these enzymes in the diagnosis of, or in order to locate where exactly is the damage in the cell. Endoplasmic reticular marker is glucose 6-phosphatase enzyme, which is present in the endoplasmic reticulum, embedded in the endoplasmic reticular membrane. Golgi complex, we have galactosyl transferase, which is present in the Golgi complex. We can use that to, which is a marker for Golgi complex there. Inner mitochondrial membrane, we have ATP synthase located. So, measuring ATP synthase, it's like act as a marker of inner mitochondrial membrane. Peroxisomes are rich in, which contains catalase. Catalases are present at high concentration in the peroxisome. Urate oxidase are present in high concentration in the peroxisome, because uric acid synthesis is going on in the peroxisome, that is xanthine oxidase there. Lysosomes, we have cathepsin and variety of lysosomal enzymes we can measure. Cytoplasm, just one example, that is lactate dehydrogenase, although we have hundreds of enzymes in the cytoplasm. Now, what are the enzymes that are present in other body fluids and used in certain diagnosis? Lactate dehydrogenase in the CSF, pleural fluid, ascitic fluid is suggestive of malignant tumors, but not really the confirmatory diagnosis there. Adenosine deaminase in pleural fluid are suggestive of tuberculosis in pleural effusion. Amylase in the urine is suggestive of pancreatitis. Now, let's move on to see some of the examples of enzymes that are used as therapeutic agents. One is streptokinase and urokinase. This streptokinase and urokinase, they are enzymes that lyse the intravascular clots, and these enzymes are used in the myocardial infarction treatment, where the clot lysis is done and recanalization of the coronaries can be done here. Hyaluronidase enzyme. Hyaluronidase enzyme, it degrades hyaluronic acid, and it is used in the treatment of like traumatic and post-traumatic edema. Thereby, so hyaluronic acid, which is an extracellular matrix, glycosaminoglycan degraded, and the edema can be decreased. Asparaginase. Asparaginase, it degrades asparagine, and it is used in the treatment of acute lymphoblastic leukemia. Because these acute lymphoblastic leukemia cells, they lack asparagine synthetase enzyme. They cannot make their own asparagine. They are dependent on a dietary asparagine, which is coming from the diet and in the blood, right? So, when we use asparaginase enzyme, this asparaginase is going to convert asparagine in the blood into aspartate, and thereby acute lymphoblastic leukemia cells, they don't get sufficient asparagine to multiply. Now, we have pepsin, trypsin, papain. These are protein digestive enzymes used in indigestion process, and also they indicate pancreatic insufficiency. During pancreatic insufficiency, we can use pepsin, trypsin, papain. These are protein digestive enzymes, so which will help in protein digestion. Because pancreatic insufficiency, pancreatic digestive enzymes are not coming into the duodenum. That means there may be malabsorption of proteins, lipids, carbohydrate. By providing enzymes, external enzymes like pepsin, trypsin, papain, they will aid in the digestion process. Alpha-1 antitrypsin. Alpha-1 antitrypsin can be used as a treatment for alpha-1 antitrypsin deficiency, because alpha-1 antitrypsin, it is going to degrade elastase enzyme, and in emphysema what happens, there will be alpha-1 antitrypsin deficiency, elastase enzyme is not neutralized. That means there can be damage to the elastic tissue leading to pan-acin or emphysema, and that can be treated by simply giving alpha-1 antitrypsin enzyme that was previously deficient. Collagenase. Collagenase enzyme, it degrades collagen and it is used in treatment of debridement of ulcer. Whenever ulcer cleaning has to be done, so that collagen that is accumulating there, it can be cleaned by collagenase enzyme, so that wound is clean and it helps in the proper wound healing process. Lysozyme. Lysozyme is an endogenous antibiotic found in human tears, and it is used in infection of the eyes. Now the penicillinase enzyme. It is used in the degradation of penicillin. So especially whenever a person is having allergic reaction to the penicillin, which will lead to anaphylactics. Okay, so that can be prevented if a penicillinase is used. And the last enzyme here in the list is streptodoranase. Streptodoranase, it's a DNase enzyme. It liquefies dead cells and pus in the wound. It can be used along with streptokinase to dissolve clot and pus. So, these are the examples of enzymes as used as a therapeutic agents. So, this is how we have learned what are the uses of enzymes in clinical diagnosis, what is the meaning of isoenzymes, different examples of isoenzymes, what kind of proteins and enzymes are used in the treatment, means in the diagnosis of myocardial infarction, how to diagnose reperfusion injury, what are the enzymes that can be used in diagnosis of other disorders. So that's all about use of enzymes in clinical diagnosis. Thank you so much.